Good afternoon, everyone. My name is Shaukat Ali Khan. I'm the Chief Digital and Information Officer for the West Yorkshire ICB. Welcome to our distinguished lecture series, our first lecture of our series. So really happy to see so many of you from different parts of UK and from abroad as well. So welcome to this one. Next slide, please. Yeah, before starting the session, we have a couple of housekeeping stuff, which I just want to remind everyone that we will be recording this session for colleagues who can't make it and be shared across communication platforms afterwards. And also the request is to please mute yourself unless you are speaking during the Q&A session. And it's also okay to turn on your camera if you wish. And if during the discussion, if you want to ask any question, then my request would be to just type that in the Q&A section so that we can pick and then we can ask Grint and other panelists. Today in our today's session, we have Vint Cerf, who is known as father of internet. So thank you so much, Vint, for your time. And then we are all really looking forward. And I'm your host today. And we are also joined by Rob Webster, CEO, West Yorkshire ICB and ICS, and also Kathy Scott, Deputy CEO, York and Humber Health Innovation Network. And this distinguished lecture series is in collaboration with the Health Innovation Network. So thank you so much. And then we will be working closely with them to bring a lot of these high profile lectures for our audience. And then you can see our speakers here. And West Yorkshire Digital Data and Technology and AI program consists of five different modules: digital literacy, distinguished lecture series, West Yorkshire ICB board development, AI specific literacy programs for AI and cybersecurity. And the idea is to have these five key areas with the overarching aim to increase knowledge, capacity, and confidence, not only the 100,000 NHS colleagues across West Yorkshire ICB and ICS, but also to our citizens, so that they are very well aware of all the features, tools, and possibilities available for them to connect remotely towards NHS services. And within these programs, we are, as you can see, we are focusing to educate and remind and refresh everyone within the Digital Data and Technology Directorate, but at the same time all our colleagues across West Yorkshire ICB. In addition, we have started the Digital Ambassadors Program to engage young generation who can help us not only to spread the digital data and technology literacy, but also be our partners in this journey. And also to all the citizens, 2.7 million citizens from West Yorkshire ICB jurisdiction, where we really want them to be engaged and then support them and then refresh their minds about what are the tools, what are the possibilities available for them to connect with all the NHS services. And with those words, I just want to request Vint to please, and of course you have seen Vint's profile in our communication. He has dozens and dozens of international recognitions, and I think if I will just start naming those, the whole session will go on that. So thank you so much, Vint. I think we are all thankful that today we are connected on internet, and you have a huge role in bringing this internet to all of us. So thank you so much on behalf of all the audience and everyone actually here. So with those words, I would like to just request Vint to have a 20-minute talk, and then we will go with Kathy and Rob, and then question answers. Vint.
So thank you so much for the invitation. I'm speaking to you from one of the Google offices in downtown London on St. Giles High Street. And I will try to blast through this in 20 minutes and then look forward to Q&A. Thank goodness this isn't called the West Yorkshire Extinguished Lecture Series, but maybe you'll come to that conclusion when I'm done. Could I get the next slide, please? So this is where the internet starts. It's with a 4-node network in the United States. And I was a graduate student at UCLA at the time. That's in 1969, which is a good long time ago. The next slide. The next big milestone is in 1977. I'm at the Defense Advanced Research Projects Agency, and I'm demonstrating a three-network internet, a mobile packet radio network in the San Francisco Bay Area, a packet satellite network over the Atlantic connecting the west coast of Europe to the east coast of the US, and the internet, or the ARPANET, which was extended into Europe by way of an internal satellite hub. That was a major demonstration, and that was quite a long time ago in 1977. Next slide shows the internet as we think of it today. This is just an illustrative picture, but the point I want to make is that there are tens of thousands of networks that are all interconnected. They each choose the hardware and software they want to use. They decide who they want to connect with and on what terms and conditions. They run whatever business model keeps them going. It's an extremely general, extremely distributed system. And of course, the only reason it works is that they're all using the same protocol suite, which is called the TCP/IP protocol suite. So let's go to the next slide. I feel it's obligatory to talk about artificial intelligence these days. So this is the obligatory AI slide. This is not a recent technology. It started way back in the late 1950s and early 1960s. The first phase was called heuristic programming. That didn't always work. If it always worked, it was engineering. Otherwise, it was AI. But that didn't scale very well. Then the next version is expert systems in the 1980s, where a collection of expert rules were introduced, drawn from specialists. So, if this symptom appears, then you should do this test. Or if this symptom appears, there's a 20% chance that your patient has this particular disease. The problem is that as we built up these if-then-else clauses, they started to conflict with each other. So the expert systems version of AI didn't work very well either. The next thing that happens is in the 2010s and 2020s, and that's neural networks, where multi-layer systems that emulate a neural system with weights in each one of the neurons, they interconnect with each other. And the result has been a phenomenon that seems to have no stopping. It's a very powerful technology. We use it here at Google. We acquired Google DeepMind some time ago here in the UK, and our main facilities are still here. That group has been extrapolating on the basic notion of neural networks since about 2010 or so, and they have had enormous success. So you're seeing some examples of that. Some time ago in 2015 or so, AlphaGo showed that a computer system based on neural networks could beat an international grandmaster at Go. And then we used AlphaZero, another version, to learn chess from zero, no examples, just the rules, playing better than most humans do. And then AlphaFold, which won a Nobel Prize for its ability to take the proteins that are generated by mRNA interpretation and assess how they fold up and what shape they take, which of course all of you must know, determines whether or not and how they interact with receptors in the human and other biological systems. But these same technologies are being used to do real-time translation, to do speech-to-text and text-to-speech, and sound synthesis. And at this very moment, I am using automatic captioning, which I'm pretty sure is being done automatically and not by human hands, using these same technologies. So we and many others have developed large language models that have the capacity to do not only text, but also imagery and audio and video and a variety of other modalities. OpenAI has GPT-5 most recently, for example. These are being used for entertainment and storytelling and summarization. So this session might very well be summarized by an artificially intelligent system that will ingest all the words and produce a briefer summary. But it's also, these technologies are also being used in the medical field, as many of you will know, for diagnosis, treatment, and even financial and policy advice. Although I would say these are very high risk And if anyone is offering services based on these technologies, they should show that they have taken major steps to minimize the risk to the consumers of these kinds of services. We're also using these same systems to do automatic programming, where you have a discussion with the system about the program you want, and then it produces the software for you. Of course, you should also be very careful to check the code and make sure it doesn't have bugs. Even human programmers create bugs, as many of you will know. We've even applied this to weather prediction.
I don't.
I beg your pardon? I guess somebody had an open mic.
Yeah.
Vint, please unmute yourself. I think you have muted yourself.
I didn't touch anything. Was I muted? I don't know why I was muted.
Yeah, we can hear you now.
Okay, all right. Anyway, I was talking about weather prediction. This was a surprise. We're using neural networks trained on 40 years of data and then 48 hours of recent data, and then making predictions for 5 days ahead with much less computing requirement than Navier-Stokes equations on supercomputers. So that was a surprise. And of course, I think I've already mentioned, not only have we got the AlphaFold program, but recently we've been looking at using these same tools to synthesize DNA and RNA. Could we go to the next slide? So just again, these are not AI systems necessarily. Some of them are, but they are examples of high tech in medical applications. For example, cochlear implants and hearing aids have come a long way since their early origins. My wife has 2 cochlear implants and they work extremely well. I wear 2 hearing aids. So we're benefiting from high-tech mechanisms that take advantage of the understanding of how humans hear. Screen readers are another example of assistive technologies, automatic captioning, which I'm using at the moment, eye trackers that are helpful for people that have motion or mobility problems. There are even systems recently that claim to recognize when someone might be locked in and yet still has a brain that's functioning, or if they are unable to move, but they can use their thinking to control a cursor or a keyboard. These are surprising but very, very powerful results. We're still in the early stages of optical implants, but some of you will be aware that those are becoming feasible, even relatively low resolution. Spinal implants are almost certainly in the future, although there have been some demonstrations recently. A problem that we have with assistive technology is that the people who build the interfaces don't always have good intuition about what makes a good interface for someone who's blind or has a motor problem, or perhaps is colorblind or is deaf. And so we need to teach people how to make these interfaces, and it may be that the AI agents will help us do that in a more effective way. Let's go to the next slide. So there are some really tough challenges in successfully producing digital health applications, in my opinion. One of my friends says that he's not worried about keeping his medical information private. He just wants to make sure it doesn't get altered. For example, if his blood type gets changed inadvertently or deliberately, the next time he has a blood transplant or a transfusion, he might die because it's the wrong type. So we want to be sure that the medical data that we accumulate has well-established provenance and integrity, and it can be demonstrated to have not been altered in any way. We also need to have some standards for metrics of how well these systems work, and also metrics for various and sundry body states and physical chemistry states. We have to have a common set of metrics so that when people are taking measurements of one kind or another, they're comparable. There is, of course, a risk if we accumulate a lot of this data and we put it in one place that is potentially a privacy hazard. On the other hand, having all that data in one place and accessible can be tremendously beneficial for public health. First of all, we might be able to detect an epidemic earlier than otherwise. We may also be able to create a kind of artificial drug trial, if we have enough information about enough patients, they may be taking various medications, we could select a subset of them and follow their progress using this publicly available, or at least public health data, not publicly available necessarily. Security and privacy obviously are big challenges for any of the health applications. I'm also concerned about resilience in general, because once we become dependent on these technologies, when they are not working, what's the backup? How do we deal with a computer failure or a network failure or some other kind of power failure, where we've become very dependent on having these technologies to help us with treatment. So once again, resilience is a very important issue. It's clear that if we have enough information about a patient over time, and if we can do some continuous monitoring, we'll have some idea of what's normal for that particular patient. I always imagine that people go in to see the doctor only when they're sick. And so the doctor's sampling of data is only when you're sick. It has no idea what you're like when you're healthy. If we do continuous monitoring, we have a much better profile of what a person's condition is. And then we can notice that it's no longer normal and it's gone out of normal parameters. An interesting, just to give you an example of the concern people have, I'm imagining, and you can imagine for a moment, that you have a health crisis, maybe it's a heart attack or some other problem, in a city that you'd never been in. What's the first thing that comes to your mind when you're in the emergency room? It's not hiding your health information. It's making sure that the doctors who are treating you have access to everything they could possibly get to secure appropriate treatment. On the other hand, after the crisis is over, assuming you survive, then the last thing you want is for those people to still have access to all your medical information. So we have to find a way of arranging for episodic access under your control in order to make the data available appropriately, but not inappropriately. So these are just a few examples of some of the challenges we have in trying to apply technology in the digital health realm. Could I have the next slide, please? So I can consider a current state of affairs in 2025 to be one of almost endless opportunity. Diagnostic technologies with AI enhancements are sure to improve the quality of healthcare. Synthesis of drugs is becoming more and more feasible, especially RNA-style drugs, for example, that can be tailored to attack particular things like the COVID virus. I mentioned already the synthetic drug trial idea, where we're just taking samples from a large population and following those people who happen to be taking the drugs that we're interested in. The synthesis of RNA vaccines is becoming more and more feasible. Public health tracking, we talked about that, personalized medicine, and of course, collaborative research and data sharing, which I think would be immensely helpful if we could have more readily available information for parties who are interested in trying to improve our ability to care for people and using technologies that, like the artificial intelligence ones, to improve the quality of healthcare. And there's so many more, but I don't have time to go over them. There might be another slide here, but I'm not sure what it is because I've forgotten. What's the next slide? It says thank you for. Okay. So that is my summary of where we are in AI and high tech with regard to healthcare. This is a great time to be alive, I think, or I suppose you could even say it's a great time to be sick, because we're likely to be able to treat you better than we could, let's say, even 10 years ago. So I'll stop there. I'm happy to give the rest of the time over, if there is any, to the next speaker, and then we'll have some Q&A as this session goes on.
Yeah, thank you very much, Vint. I think it's a lot of insights, and then we will further explore the details and then a couple of other elements as well. So now I just would like to invite Kathy Scott, who is our Deputy CEO for York and Humber Health Innovation Network, to tell us about more based on the discussion, what is the context, and especially with regards to our NHS 10-year plan, how this can be contextualized in NHS world.
Thank you, Shaukat. And thank you, Vint. That was absolutely fascinating. And I don't really know how I'm going to follow that. So as Shaukat said, I'm Kathy Scott. I'm Deputy Chief Executive for Health Innovation Yorkshire and Humber, and we're one of 15 health innovation networks, or HINs, in England, and we have two main roles. So we support innovators to develop their good ideas into scalable solutions, and we support the health and care system to adopt proven innovations at scale and at speed. And we do this so that we can improve patient outcomes and safety, reduce costs, and promote local economic growth. And I just wanted to touch on what I see as the definition of innovation. So for me, it's something new, or it's something existing used in a new or different way. So it encompasses all the sort of sexy stuff and exciting things like AI and digital, through to what people might see as less exciting stuff that is on the ground, things like ways of working, small changes to pathways, how staff are treated, how you work together. So it's really wide ranging. And improvement, for me, is the flip side of innovation. It's how we ensure that change is embedded and sustained. So improvement and innovation are, really tightly linked together. And the 10-year plan relies heavily on innovation to achieve what looks to me like a really stretching vision of the future. The 10-year plan references genomics, wearables, the NHS app, single patient record, and artificial intelligence. So it's just as well that there's a lot of really exciting stuff coming up. So in addition to what Vince has talked about, there's also use of AI in eye examinations to identify physical and mental health conditions before they actually arise. Use of genomics to identify likelihood of disease, and then we can take action to prevent it. Ocular implants, as Vint mentioned, not to correct sight, but to continuously monitor biomarkers, and then feeding that information into AI to give early warning of disease and deterioration. And apps that this is already out there, apps that can listen to a stock phrase or you repeating a series of numbers and identify the likelihood of an adverse event. For example, congestive heart failure exacerbations in the next few weeks. So really exciting stuff. But thinking about the advancing of innovation to meet regional healthcare challenges here in West Yorkshire. So it's really important to understand the challenge. If you can't understand the challenge, then how can you know what innovation is relevant? It's also critical to understand the system, the ecosystem, and the local context. And I think failure to understand these really risks the advancement of innovation in any setting. We've seen it before where there's an assumption that because you did X, Y, and Z here, you can pick up the innovation and do X, Y, and Z there, and it will work the same. But often it doesn't because of that local context.
Yeah.
So that's why our Innovation Hub, which has been instrumental in bringing these distinguished lectures to you, is so critical. It's between the West Yorkshire Health and Care System and Health Innovation Yorkshire and Humber, and it reaches into the system and into the world of innovation, bringing people together, identifying challenges, finding solutions, and overcoming some of the barriers to innovation, which I'm sure we'll touch on later. Some examples of innovation, technology, and system improvement that the Hub is progressing. So we have earlier detection of chronic kidney disease at home with a company called Healthy.io. So this innovation is a home albumin to I can't say this, I've got it written down phonetically and I still can't say it, creatinine ratio test done with a smartphone, and results are available within minutes. This was a West Yorkshire project which ran from March 24 to February this year, and it sent out thousands of kits so people at risk could test at home. What we found, the reason for this was that when we looked at the people at risk and the number of them who went into hospital to have the test, take-up was really low because hospital appointments are inconvenient, people find it difficult to get there, they'd rather be spending time with their friends and family than looking at something which might warn them of something in the future. But this you can do at home, it's really convenient. We delivered over 6,000 home tests. We've been supporting faster, safer cancer triage. So Pinpoint AI is a blood test-based AI tool developed in Leeds, and that helps triage urgent suspected cancer referrals. And that means that waiting lists can be prioritised more effectively. The innovation is CE marked and fully regulated for NHS use across 9 cancer pathways, and the West Yorkshire Innovation Hub is supporting further spread and funding conversations. And then cardiovascular disease screening in communities. We know that some communities don't go for screening, again, because it might be inconvenient. They don't know that they're at risk. So this is a smartphone-based check that gives a full cholesterol profile, heart age, and 10-year risk from a finger prick sample in minutes using a PocDoc app. This is currently being rolled out in Huddersfield and Wakefield and community pharmacy sites. And because we go out into the community to do it, to places where people are, it helps us reach people at higher risk and therefore reduce heart attacks and strokes. And then some exciting stuff that's coming up with a West Yorkshire digital twin. So a digital twin is a virtual model of a patient created via data that you get from imaging, biosensors, genomics, and so on. Extended reality lets clinicians and patients see or interact with the twin in 3D or immersive space. So as an example, in cardiology, you could model the heart and torso, you could visualize in extended reality to plan interventions, see what would work, what would be less successful. So the University of Leeds researchers are building AI-driven digital twin to test medical devices and computer simulations, and that's going to make trials quicker and safer. And the Leeds Teaching Hospital, Hospital of the Future, also includes digital twin technology to monitor and improve performance. And this will give West Yorkshire the research and development and operational test beds to prove what works before scaling. And we're starting off around kidney failure, kidney disease. So that's really exciting. But as Vint did, it's really important to acknowledge the risks of digital and innovation. And it can be a difficult tension to manage. Patient safety is absolutely paramount, and we can't take risks with that. But risk aversion can stifle innovation and change. And that's tricky when we know we need to do things differently. A lot of innovation isn't patient-facing, or it would cause zero harm if implemented, but we tend to apply the same risk appetite to all innovation, regardless of the actual risk. And it is absolutely and entirely right to apply high quality standards and baselines to innovation that could potentially harm patients. For example, AI diagnosis, if medical decision making is not brought into the fold, that is potentially dangerous. AI has the potential to be biased and it may not apply the same levels of empathy and decision making around circumstances that a clinician would bring. And we know that patients and clinicians are happier using AI if the decision is made by the clinician based on data and evidence brought to them by the AI tool. And this has been confirmed in a study by the Yorkshire and Humber Applied Research Collaborative. When AI is used as a tool with clinicians as the decision maker, then the risk to patients drops significantly. And when you add in standards, evaluations, evidence, quality baselines, proper training, and a variety of other factors, then the risk is reduced significantly. And where the innovation is not patient-facing, for example, in estates or back office functions, we need to ensure that decision makers who make decisions around finance, procurement and similar understand that the innovation, that doing something new will always involve a level of risk. And this is where culture is so important. If there is a culture of fear of failure, then innovation won't flourish. But if staff know they can bring ideas, make suggestions, carry out changes, have the autonomy to make decisions and understand the delegated authority, then innovation is more likely to flourish and advance. So I guess what I'm saying is that the risks of innovation can be very real, as Vince has outlined, but with proper guide rails in place and the proper culture, then the risk can be reduced. Innovation can flourish and advance as it is doing in West Yorkshire Health and Care System. Thank you.
Thank you, Katie and Wint for inspiring thoughts. And before I open the questions, I would like to just, Wint, do you have some initial thoughts you want to share?
Well, first of all, Kathy, that was a wonderful summary. Thank you so much for all the examples that you gave. I was going to raise a few questions for you. One of them has to do with false positives and false negatives, and those are elements of risk. So I hope that part of the program is to track that to validate whether or not the diagnoses are accurate. On the digital twin idea, I just came away. I was in Heidelberg, Germany last week for something called the Heidelberg Laureate Forum, which brings people who've gotten major prizes in mathematics and computer science. And they were showing an example of a full body scan, MRI scan that had been turned into a part of the digital twin so that they could see if they were planning an operation, for example, you could see the actual shape of the spine or the heart or some other organ that needs attention. And I've even seen hospitals where I come from in the Washington, D.C. area doing 3D printing of a particular part of the body in preparation for surgery to figure out how are we going to get into this thing. So these are all examples of the kinds of technology that are going into healthcare today, which are amazing compared to what we would have seen even 20 years ago.
Yeah, the pace of change has really accelerated, hasn't it? In answer to your first question, I think what we find is that people get every bit as excited about what could go wrong as what could go right with something new. So yes, the false positives is very much at the false positive, false negatives, very much at the forefront of discussions.
Yeah. Excellent. I think we will continue the discussion, but before bringing other questions, I would like to ask Rob if you have any initial thoughts or questions you want to add at this point.
Yeah, thank you very much for both of those presentations, Vint and Kathy. I thought they were both very thought-provoking and framed really nicely in terms of this conversation. In terms of where we are in West Yorkshire and where we're going as a health and care system nationally, I think there's a few reflections I'd have on what we've heard and what we know. So the first is that, the 10-year plan for health and care in this country has digital and innovation and data and AI very much at the forefront and at the centre of what happens next. So I think there's a sequence of bigger bets, is how it's phrased in the 10-year plan, around this agenda, which says, look, we've got to back these things because it will be the way in which we have a sustainable health and care system at all. And I was at the Global Impact Committee meeting last week, featuring people from across the globe, looking at where everybody's going at the moment. And it's pretty clear that the workforce deficit that most countries face when it comes to health and care, the financial issues around delivering affordable healthcare, are driving everybody into this space. Now, what both speakers have identified is the huge amount of opportunity that there is and jeopardy. And one of the things that's pretty clear is that we don't have an ethical framework that everybody's adopted for the utilisation of AI. I think we've got existing ethical frameworks when it comes to things like medicine, but if you think about and data, but what's our overall ethical framework for decision making around the adoption and dissemination of artificial intelligence, digital tools, and non-human facing innovations? Something that we need to think about quite carefully right now, given the explosion of opportunities that there are in this space. And allied to that, I think Kathy talked quite clearly, and both speakers touched upon culture. And I've always been a fan of trying to create the right infrastructure and the right culture to innovate. You have to have both. And that was very much demonstrated by both speakers. So people who feel able said, you know what, maybe if we tried it this way, or if we thought about deploying this technology over here, it might make a difference. And some of those people might actually be citizens or patients or carers, as well as scientists, mathematicians, and medics. And I think we're creating that culture here. And then having the infrastructure with something like the Health Innovation Network, which allows us to test, assess, evaluate, deploy together is critical. So I think that cultural and infrastructure point is something that we should test. Are we definitely getting there with those elements? I think the third thing I just wanted to draw out was I think we've talked quite a bit, I think, about data, and we know that we don't have representative data. We know we don't have it. We know that the majority of genome sequenced are Northern European white people, or from the Northern European genome. That cannot describe the whole of the globe, or does not provide us with the research foundation to deploy new technologies, and we have to be honest about that. We know we're underrepresented in many of our data in the healthcare system, even in terms of codifying people's disabilities, faith, ethnicity, sometimes gender. So there's quite a lot of work for us to do if we're going to build something that requires significantly good positive data. We need to think about data collection differently. We need to think about research very differently, and we need to be very questioning of ourselves in terms of the veracity of what we're doing and the power of what we're doing. Having said all of that, if we can do that well, if we have the right ethical framework, if we have the right culture and infrastructure, if we have the right data and the right investments, then we maybe can hit the thing in the 10-year plan that we want to deliver, which is a different way of delivering healthcare, which maximizes the opportunities to improve people's health with the resources that are available. I can see that there are lots of questions in the Q&A already, so maybe I'll stop talking now and we could get into some of those questions.
Yeah, thank you, Rob. Very interesting, and I think you have put together the entire like in a really amazing way. So as Rob mentioned, we had a lot of questions, but and I have requested Natalie Schofield to just monitor the questions and maybe just ask a couple of questions. At the same time, I would also request all the participants that if you have questions, just raise your hand and then we can give you the floor. Natalie.
Thank you, Shaukat. So I will pick a couple of the key questions that I can see are being liked in the chat. So the first one is from Frank Wood. Frank's questions relating to the way that we collect our information, and also recognising Vint, Rob and Kathy, how you've spoke about the importance of the validity of the data to which we can deploy some of our most advanced capabilities like AI. So Frank's question is, how do we ensure the electronic health record data we have is representative of the whole population and takes account for bias towards groups with less contact with health services in the way that we use these data? So perhaps if I could ask yourself first, Vint.
First, I have to unmute. Well, first of all, getting adequate amounts of information that's representative is a challenge for each individual and also for the population as a whole. And so what we are going to have to do is start tracking what information we have and to analyze it for holes, so to speak, and vacancies that need to be filled. This leads me to suggest that there ought to be more information sharing. We need to find a way to allow doctors everywhere to share patient data in a way that is safe and secure, keeps privacy in mind, but allows for the healthcare system to be much more comprehensive. This is going to may take a cultural change where people recognize the value of sharing their own personal health information. It benefits everyone because they'll have access to others. It's like a mutual insurance policy. But that's going to take some culture change, and it's probably going to take some serious technology to make sure that we have proper access control or anonymization or both in order to assure that those aspects are attended to. But the value of having that comprehensive data is incalculable.
Rob, you want to come in?
Yeah, I mean, I think it's a brilliant question. Firstly, we've got the benefit in the English system of having list-based general practice, which means that just about every citizen, over 99% of us, is registered with a general practitioner. All of those records are coded in exactly the same way, and the data are as up to date as they can be clinically, because general practices are incentivized for that to be the case. So that kind of there's a starting point which is pretty good for us. We've also then got very, very variable secondary care systems and systems which aren't interoperable, and that's where the Yorkshire and Humber healthcare record work comes in. So we could view the world through that lens and maximise the amount of opportunity we've got from the data that we have. We also know, though, that people accessing general practice face the inverse care law, and that those who need the most care get the least. So it's a skewed set, and we need to do something about that. Now, what I would want us to really start to do is to get out of our medical and healthcare box, if we can, because there's a whole industry a whole health industry which isn't connected to the NHS. I've got my Garmin smartwatch on today, which is measuring my blood, my all sorts of things, my heart, what happens when I sleep, etc. That data goes somewhere, and this whole industry is collecting huge amounts of data, just getting on with it. And I think there might come a time where it just gets on with it without thinking about if it ever needs to be interoperable with the health service and the medical system if we're not careful. And I think we're now in a position where, GPs are sitting in consulting rooms with people coming in having a chat GPT summary of what symptoms they've got and what the summary might say they should be asking for and getting as they enter the practice. And then we've got a load of health businesses which are collecting loads of data, and we need to be able to harness both of those somehow. So if we can get out of our medical box into what the public are doing and what industry's doing and try and connect the data up safely, we might end up having more data that's more representative. We might also not if we're not careful. So I do think this is a space where we need some careful consideration of what's available and how we maximize it. And if there are deficits in the data, how we correct for those as much as possible.
Thank you, Rob. Kathy?
Thank you. So I think where we're looking at where we've got gaps in the data, perhaps we ought to be asking those people who are part of the gaps why, rather than just making assumptions. Let's bring in patients here. And then the other thing for me is about trust. At the moment, I think there's a trust issue with government and that extends to the NHS, which is interesting because in a way there isn't with some of the private healthcare providers who, like, I've got an Apple Watch on. I'm not sure that I trust Apple Watch with my data, but it's so useful to me that I'll let them have it. But if we can improve trust in the system with what we're doing with people's data, if we can show them the benefits, then maybe we'd get a more representative sample.
Thank you, Kathy. I think we have a lot of questions. So Natalie, maybe you can just summarize the other question and then we can take from there.
Thank you, Shaukat. So I think we should stay on the similar topic around devices and wearables. So we've just heard from a number of our speakers around how technology can be used to empower our citizens to be kind of informed consumers of the healthcare system. There's a question that's come in from Hannah Clemens. The 10-year plan speaks of utilising wearables to monitor health conditions. So what specifically are the panel's views on the challenges and opportunities of things, as you've just all discussed, around smartwatches and wearable devices in healthcare? So again, if we could come to Vint first, and then it'd be great to hear reflections from Rob and Kathy also.
So, one of the things that occurs to me right off the bat is that using these wearable devices for medical monitoring requires some kind of calibration. And so on top of everything else, we would have to have confidence that these devices are actually capturing information which is, what's the right word, commensurate. If we will almost, in the US, there's this organization called the National Institutes of Standards and Technology, and they calibrate medical measurement devices using materials in order to verify that the data that the sensors capture is accurate. And so I don't think that very many of the wearables production community has gone through that sort of calibration that they probably will have to if we begin to rely on this for medical detection of emergencies or even just normal monitoring of body function.
Yeah, Rob, you want to add anything, or Kathy? I think just to add that the 10-year plan is also a welcome for all of us to explore and go into more deeper into all these possibilities, and then how they can be actually measured and then they can bring value in our context. So I think if we can just read the 10-year plan, of course there are not a lot of answers, but there are a lot of options and a lot of possibilities where we can explore and then come up with dealing with all these questions, open questions, or the possibilities for our future. Rob?
I'll let Kathy go first. She's unmuted.
Thanks, Rob. So I think it's really exciting. And when I first started in the innovation space about 10 years ago, test beds were going, and one of the test beds, so this is bringing together. The idea was that you had glass, you had tungsten, you had electricity, but until you brought them all together, you didn't have the light bulb. So what could you bring together to make innovation really flourish? And so some test beds, one of them was looking at if you have people who are at risk of falls or have dementia living in sheltered accommodation, how could you bring together lots of different innovations that might help you identify when they were more at risk of being ill? And that included wearables. And I think we're beginning to see that as a more of a reality now. But I guess one of my concerns would be, what can the NHS afford? And will you end up with a two-tier health system? So I have an Apple Watch because I bought it myself. So would I get better data, more extensive data going into my health record than somebody who couldn't afford that, who might get a basic model of something else from the NHS that maybe wouldn't give as accurate data or as extensive data? And then the other thing is I could see a future where the NHS would buy single-use wearables for single issues that might then, so you might have one for your blood pressure, or you might get one for your glucose, or you might get one for whatever your issues are. But then you wouldn't get a fully rounded picture, and the NHS would end up spending money on lots of little things rather than looking at the bigger picture, which I think we maybe have done in the past.
Thank you, Kathy. Vint, do you want to comment?
Just thinking a little bit about remote medicine. During the COVID period, a lot of doctors said, don't come to the doctor's office, call me up or do a video call. Having wearables and other kinds of sensory systems makes remote medicine more feasible. And I'm rather excited about that because it's an opportunity to intervene and to detect conditions that might otherwise not get the attention that they deserve. So I'm a big fan here, but I do think that the calibration question is very important. The ability to assess the quality of the information before it goes into your health record.
Thank you, Vint. Rob?
Yeah, so we have the Medical Devices Agency that can be deployed to assess and calibrate any devices that are used in medicine. So that would be the easy and straightforward step, I think, in that space. I just want to talk about unintended consequences, and they can be positive or negative. We've got a history, haven't we, of using fall sensors and other materials in usually in the homes of the frail elderly, which are connected to some central point with a response as required. I was in Holland a few years ago, and there was a really good scheme there where they worked out they couldn't afford their out-of-hours care for older people. So they worked out that why don't we map everyone who can get to somebody, because they're either in the house, in the street, in the neighbourhood, or in the town where we belong, and that'd be multiple agencies, and we'd have a deal where we'd work out who the nearest person went along. And the sensors were quite sensitive, and a lot of the time there's a lot of false reading. So there was an interface which frail older people could use, and it was quite simple. It was simplified to ensure that they could, because they might have memory or dementia issues, that they could turn the system off and on and respond appropriately. And to get them used to it, they had a training program which was gamified, and they could talk to other people who were also on the system. And what happened quite quickly was that they started playing games with each other, and they created a community of people who actually had some connections and were less lonely. And that meant that they kind of improved, the level of call outs went down, and the kind of social connection, and they started going out of the house and meeting each other. So you can have some unintended consequences of these things, which are really nice, but you could also have some unintended consequences which aren't. And I can imagine that there will be many people who view with suspicion a suggestion that in the 10-year plan that states your genome will be sequenced at birth and the risks will be provided to you and your healthcare provider, and that you will, with people with long-term conditions, will be given wearables. You immediately get into incentives, but also what happens with non-compliance. And this is why I think some of the issues around the ethical frameworks within which we operate are important, because it's not beyond the realm of possibility for there to be disincentives or consequences for people who aren't compliant, which may or may not be the right way forward.
Yeah. Thank you, Rob. I think we just have time for one more question. So maybe Natalie, just summarize if you can to get a theme. Thank you.
Thank you, Shaukat. Okay, mindful it is the last question, and I think it's a common theme throughout the reflections from our panellists. We know that it's a known issue in the NHS that healthcare data is fragmented, locked in silos and inconsistent, and can be at risk of exacerbating health inequalities. So we have a question in from Burhan Ahmed. His question is initially directed to yourself, Vint. From your experience with the open web, what lessons can help us build interoperable systems that also guarantee provenance, authenticity, and ethical use of healthcare data?
So this reminds me of the final exam in the physics course that says, describe the universe in 25 words or less and give 3 examples. But the question is, of course, absolutely valid. At Google, we've done considerable work trying to work with others on standards for data representation for metrics and so on. We also have a system that we refer to as the data commons, which is a way of ingesting large amounts of statistical information of a variety of types into a coherent data collection where all of the information is commensurate and therefore can be analyzed and processed in a consistent way. So the point, though, is quite well made by the question, which is the healthcare agencies like NHS and the US, others, as well as even private sector providers, need to agree that they want to have commensurate information available to go into a common database for patient records so that they can be accessed under the right conditions at need and be useful in the process. The wearables initiative will probably provide incentive for some of those standards to be developed. At least I certainly hope so.
Thank you, Vint. Maybe I will just take the liberty of one non-digital health question, because we have one question where it's our participants are asking. In a recent podcast interview, Sir Tim Berners-Lee, inventor of the World Wide Web, was asked what he regretted about the development of the internet, and he said that the creation of addictive social media was causing harm. Is there anything, Mr. Vint Cerf, regret about how the internet has developed?
Well, I will say that in the early days, of course, it was a wide open environment and everybody was comfortable sharing all kinds of things. And then as time has gone on, we've seen people use these technologies in harmful ways. And so the point that Rob was making about ethics suggests that we should be looking for accountability here for good behavior and also liability for bad behavior. It's troublesome, though, because this is a global phenomenon. And so you have bad behavior in one jurisdiction and victims in another, and there has to be international agreement. A cybercrime treaty was just recently agreed in the United Nations, for example, that would enable some collaboration and cooperation. But we have a long ways to go here. By the way, just for the record, I was one of the co-creators of the internet, and Tim Berners-Lee, the World Wide Web, which is a layer atop the underlying internet. The two are sometimes confused, but of course the two together have become hypergolic, and which means that mixed together they explode. So we do have real problems, as we always do, with powerful technologies that can be abused. we have to find ways of governing that. And that is going to be a challenge for the remaining part of this decade.
Thank you very much, Vint, for a very inspiring talk, and of course, Rob and Kathy. As I mentioned in my earlier introduction, that over the next 12 months, the series will bring national and international leaders and subject matter experts to share insight, best practices, and understanding of how digital data, technology, and innovation will support the delivery of our 10-year plan, which has just been released in July, and health science sector plan in health and care systems within the context of West Yorkshire. So with these words, I would like to just request Rob to do the closing remarks and thank.
Thanks, Shaukat. So I think we have started off the process of this Distinguished Lectures series with a brilliant hour. And we could have easily spent about 3 days on the topics that we've been discussing here. It sounds like a whole conference worth of material. So I'd really like to thank Vint and Kathy for their thoughtful contributions, and recognise that this is really part of us getting to a position where we understand the world that we live in, because it's real. All of this stuff is happening now somewhere, it's just not evenly distributed. And we need to be trying to shape and manage and exploit the opportunities of this work in a way which fits the values of our system and our organisation. It's not going to be straightforward, but that shouldn't stop us from taking the opportunities. And I really do think we have to be very thoughtful about our risk appetite in this space, so that we aren't paralysed into inactivity because of concerns about what might happen, when we know that what currently happens is harming people. So I think there's a huge amount that we could do here, and I'm really looking forward to the rest of the series. Thank you to Shaukat, Natalie, and the team who've put this together. Thanks again to Vint and Kathy, and I look forward to seeing you all again next time.
Thank you so much, Rob. Thank you, Vint, Kathy, and all the participants here, and my team at DTEC, and also the Health Innovation Network, our partners. So thank you so much for your efforts, and have a very nice afternoon. Thank you. Bye-bye.
Thanks so much. Bye for now.